Good morning, everyone. So we've welcomed you to this exciting session of live surgery, starting with deep lamellar keratoplasty. I think live surgery is always a great way to learn because you can actually see things happening on the go and you can interact with the surgeon. And uh, no better person than Dr. Rajesh Fogla, who is the surgeon today for deep lamellar keratoplasty, to teach us. He's a teacher of teachers. And I think he needs no introduction. He's one of the brains behind this forum as well. I would like to introduce my co-coordinator, Dr. Nimisha Shah, and the panelists, Dr. Ritu Arora and Dr. Namrata Sharma. Both need no introduction, very, very senior professors and Konya, again, teachers of teachers. I think we'll get started without further ado because the patient is already induced. And we'll wait for them to give us details about the case. I believe it's a case of keratoconus, but we'll wait for other details.
Good morning. I'm Dr. Parul. So Dr. Fogla will be presenting the case of a 19-year-old male with bilateral keratoconus. His BCVA in the left eye is 6/60, minus 12 diopter spherical with minus 1.75 diopter cylindrical at 30. And he has a little bit of apical scarring. The thinnest pachymetry is 312 micron. And this is the ASOST photograph. And you can also see the pentacam. So over to Dr. Fogla.
Yeah, good morning, everyone. I hope I'm audible.
Yes, you're audible, Dr. Fogla.
Good morning.
The video feed has suddenly gone. Yeah, it's back. It's back.
No, we need to see the operating microscope view. Yes.
Yes, we can see it now. Maybe the brightness can be a little lesser. It's a little overexposed.
On the microscope, it's good. I think it's somewhere
okay. I
in the
think
video.
Maybe the video feed people can adjust the brightness on their end.
You should be comfortable. I think that is most important. What technique are you planning to do in this?
This patient has an apical scar, and there's a small scar in the posterior layer as well. I feel we might be able to get away with a big bubble technique, but I may not overinflate because I think that you might develop a mixed type 1, type 2 bubble as well because of this scar in the posterior layer. We'll see how the air injection goes. So I'm using a Trifine that's about 8.75. So that's a, sister, you like to help. You have to. ये आपको पकड़ के रखना है. When I say press, you have to press.
So what is the standard size you normally use, Rajesh?
Normally between 8.5, I think, is the most common. This one you can see, this is the 8.75 Hesburgh-Barron suction Trifine. It has this peripheral 2 rings where you get the vacuum, and the innermost is the cutting blade. So I'm going to retract the blade a little bit, maybe about 5 or 6 quarter turns, so the blade goes back.
So we remember seeing in the topography that it was a fairly small central cone. Would you, if you were to see a larger cone, how would you decide about the sizing?
I think we look at the pachymetry map.
Yeah.
And then decide as to what, press it. And then decide where the normal thickness is and where you can go ahead. Like in this case, yes, it's about 8.75 look to be the right. Release it.
So what would be your pachymetry, Rishi, if you were to decide between a big bubble or a manual dissection as far as the host pachymetry is concerned? Is there a cutoff where you would say I wouldn't attempt a bubble and I would go in for manual rather than considering given the fact that there is no posterior scarring?
So in my case, I have a very low threshold for going to manual. And essentially, if it is very thin, if the working space is less and you feel that you may not be able to safely introduce a needle, then I think it's a good idea to think about a manual procedure. And especially if the peripheral cornea is involved, like a pellucid or something, or a keratoglobus, then you may want to consider a manual rather than a big bubble. That's what I would do.
I normally look at it if there is a scarring in the deeper layer. I would prefer to go with manual. Otherwise, I would attempt bubble in almost every case.
So you can see that we got the triffination. It's a fairly well-centered triffination within these 4 marks that I made. And you can see that that's a fairly deep triffination that we got.
So
now you can
attempted roughly 250 micron depth, or maybe 300?
This is about 7 quarter turns. 7 quarter turns would be about 420 microns.
Okay.
So before we do the air injection, I'm going to do a partial debulk. Since the apex is very thin, I will not attempt to bare the apex because then the air injection becomes a little difficult. And the idea behind debulking is that I can deflate my bubble quickly once it forms. So that's a stromal dissector which I'm using. You can use any lamellar dissector. Be careful if you use a crescent, because crescent is usually very sharp and it cuts very rapidly.
So Rishi, in which cases would you prefer an open dissection or a closed dissection? Here we see that Rajesh is doing an open dissection, which means under visualization. So would there be a situation where you would prefer a closed dissection?
So I think the purpose here is to just debulk, and because he knows there's enough safety below that, a layer by layer open dissection is good enough for this. But in general, I don't like to do an open dissection. My technique, I just create a peripheral groove and then peel, and that works well in my hands. For a big bubble, I think this is a great idea to debulk so that you're at the right depth.
I used to do a closed dissection early, but then later I realized that when I do this kind of debulking, the bubble formation is easier because the roof is thinner, and plus the visualization is also a little better.
So Dr. Fogla, can you tell us about this instrument you're using right now?
No, this is a 27 gauge bottom port cannula. And prior to this, I used the pointed dissector just to make the small track.
This is from stores?
Yeah, this is from stores. And now we are going to go ahead and do the...
So as we can see, he's gone in the paracentral cornea, and that's
side port.
A successful bubble.
Very nice.
As he's got the bubble, he's creating the side port to decompress the anterior chamber. And now he will inflate. Very
important to decompress so that you create a space for bubble to form.
So that's a classic type 1 bubble with the central translucency and a feathery white border, and it's come till about the trifine edge as is expected and desired.
I think textbook like picture or demonstration of how a big bubble should be done, and it came out just beautifully done.
So once you got the bubble, and you can see it's already reaching here, it may not have reached there. I'm not going to inject anymore.
Not needed. Not needed.
Side. If you want, you have syringe with air. Give me a normal camera. Wait. So for people in the audience where you want to show them the small bubble test, you can just see that I'm going to... Yeah, you see that? The air bubble in the AC remains in the periphery. It's not coming to the center.
Yeah.
And as I deflate...
So it's a very important step he has demonstrated, putting a bubble in the AC to make sure the type 1 bubble is formed.
So are you on an intraop OCT microscope, Rajesh?
Yeah, but I don't know whether it's working because they just got it installed 2 days back, the Rescan 800, but we don't have the Zeiss technician here.
Oh, otherwise,
so we are not able to. Otherwise, I would have shown you.
It would have been
IOCT.
A very nice demonstration of
the
various layers and also the side view.
They have the RTO 800 with the heads-up display. Since I have never done with the heads-up, I decided not to go ahead.
With the heads-up, it's not easy to do corneal surgery. You can do, other kinds of surgery with a heads-up.
Posterior segment is okay.
You can do cataract, you can do posterior segment.
Oh, okay.
But to do corneal surgery, I think an ocular surface gets a little complicated with the heads-up because everything becomes, so big and it becomes difficult to focus there.
I think that small peripheral bubble sign is very useful, especially if there's a lot of, emphysema in the central cornea and you're not sure if you have a bubble. Sometimes you get anterior emphysema and then you get a bubble underneath it. And that's where I think really comes in handy to know if you've got a bubble or not.
So, can they shift it to the oblique illumination, because this retro is not helping at all? It's kind of earlier. This is much better. I think you've stained the area where you are going to give the stab incision with the gentian violet, or
yeah. So sometimes what happens is you're not able to figure out where exactly you have entered.
So it is good to put a gentian violet stain so that you know where actually you are.
Where exactly? Because for people who are starting out, sometimes you accidentally create an opening which is very small, but then later on you cannot identify where exactly you made the opening.
Yeah.
So if you have that gentian violet mark, you can see the cut in between, so it's very nicely visible. It doesn't get lost in the emphysema.
Can you reduce the light little bit, Rajesh?
Fine, you know.
Because it's too overexposed out here.
For me, in the
If you're
operating
comfortable,
field,
then I don't want to disturb you.
I will try to see what is the
I
bare
think
minimum.
he can continue like this.
Yeah, this is better.
It's
much
going
better.
to be a brave slash
much
now.
better. Much better.
Yeah, the brave slash already done. You can see the air bubble is in this center. And it's important sometimes, like here you see the margin of the trephination is also not clearly visible at times. So for people starting out, you can also mark the edges of your trephination so that you don't overcut when you're dissecting.
Do you put visco on this area? You've already put a visco? Okay. The slash?
You can put visco to retard.
Dr. Fogla, you finished the brave slash. We didn't even notice.
Yeah, that was it.
So, can you give us some tips to avoid perforating the bed when you're doing the brave slash?
I think it's important that you decompress the anterior chamber. Kind of, your speculum should not be too tight, and you have to be brave in the sense, no hesitation. If you are doing that brave slash, do it in one swift motion. The cutting edge of the blade should be facing upwards, not down. And remember that when you put the blade in, that's not when the air leaks out. It's during withdrawal of the blade. So you should be very quick when you are coming out.
I think that's a very important point.
But putting a layer of cohesive viscoelastic on the surface and passing the blade through it is also great, because that also ensures that you do not, the air escapes gradually, so you don't have any problem.
And also it magnifies the area where you're going to make a slash. So for that second, at least, when
you can see better
when you're putting the blob of viscoelastic, so the entry would be larger than what you have actually made.
Any specifics about the scissor which you are using?
This is a scissor. Again, this is the one that I use is from stores. You can see they are blunt tip, and the lower blade is slightly longer.
So the tip is blunted, right? It's only
tip
cutting
is blunt,
from
it's not
the
a sharp. You can see again, this is the right side. The lower is a little bit longer. It's rounded. So that ensures that you don't apply any kind of pressure on the posterior layer.
He's a master, so he's going like that. But to all the beginners, I think it's always better to go a little slow and actually watch what you're cutting.
Yes, absolutely. Completely.
Because a lot of mishaps only happen at this time.
So we were discussing whether you put viscoelastic. I think I would put viscoelastic and then do the dissection, but Rajesh has shown very well that you can do it otherwise also.
You can
What
do it,
about
yeah.
you, Rishi?
So if you are putting a viscoelastic, I think it's very important that we should not put a dispersive viscoelastic like HPMC, because sometimes it can leave particulate matter in the interface, which can look quite unsightly when you see the patient post-op.
Only Helon, nothing else.
Yes, only sodium hyaluronate would be a good idea.
No other alternative.
And always, if there are any fibers, you need to separate them before you put your scissors, because my bubble didn't go all the way to the periphery here. So you will see that when I'm coming to this part, I'm doing a little bit of dissection, which can be done using a dedicated dissector, like the TANS marginal dissector, or you can use even the blunt edge of the blade to separate those fibers.
Actually,
this
you can
ensures
see
that
the
you get
air
a nice...
which he put, which had gone in the periphery after he has decompressed, that same air
come
bubble
to
has
the
come in the
center.
center.
The video feed is
Transmission,
gone. Yeah, it's back.
So you can see that I'm just... If you don't separate these fibers, what happens is when you're trying to cut, the posterior layer gets pulled up, and
Yes,
with the
and it
scissor,
can
you can
pinch.
end up perforating.
Start kar de. Dr. Fogla, if you don't mind, we have a couple of presentations from the last session.
You can
which
go ahead.
weren't-
You can
we'll
go ahead.
complete those and then we'll come back to you in a bit.
So I think this video will remain on one of the screens.
Yes, the
for
video will
audio
keep
visual.
running on one screen if it's possible. Is it possible to split the screen?
Yeah,
Yes.
they have split it.
So we'll request the second last speaker from the previous session, Dr. Priya Srinivas, to quickly come and present her case. Is it a demon in disguise?
I think she's not here.
Is Priya here? She's here.
She's there. Can we have the video playing on one side and
Yes.
the
Yes, it's going on.
Okay.
So Dr. Priya is medical director at Shri Eye Care, cornea specialist, LASIK and refractive surgeon, cataract surgeon, and she's done a fellowship from Shankar Nethralaya, brilliant surgeon. She's from Mumbai.
A very good morning. At the outset, I'm thankful for this opportunity. Although the circumstances under which I'm presenting with the live surgery going on, I'm sorry, I will not take much of your time. I would wish for the panelists of the earlier session and to give me inputs regarding this case. With that said, let me start with this case presentation. She is a 37-year-old female who presented to me with redness, pain, and discomfort in the left eye with what appeared as a growing mass. It suddenly appeared 2 months ago. That's what she reportedly observed. And systemically, her history was insignificant except for thalassemia minor. She was earlier seeing another ophthalmologist from where she was referred, and she was on and off steroid antibiotic drops prior to being referred. She got partial or no improvement with her discomfort, and obviously the mass didn't respond to the earlier course of treatment. She was emetropic, bilaterally 6/6. Clinically, she had a quiet right eye and temporal subconjunctival lipoid deposits looking like an early pingicula. However, the left eye showed a temporal conjunctival mass which was around 3 millimeter by 2.5 millimeter, 1 mm away from the limbus. There were corneal staining spots, SPKs, corresponding to the lesion, which were probably because of Dellin effect. What looked like a single large feeder vessel with some inflammation temporal to the conjunctival mass. The overlying conjunctiva was not freely mobile, but at the same time it wasn't fully adherent. So it was mobile but partially over the mass. Intraocular pressure was normal, fundus was normal, there was no lymphadenopathy, and gonioscopy was normal. So this is how she presented. There is a subconjunctival mass with some vascularity, with no fluorescent staining, and Rose Bengal staining was negative. So the diagnosis was a bit, I was at a dilemma. The diagnosis was a bit unclear. So my working plan was I have to treat it like a conjunctival mass. I have to rule out an OSSN. I didn't know whether it was a amyloidosis or a lymphoma. I first discussed with the patient the options that I would be, what options we have. So just to start with, just to relieve her discomfort, I started her on topical soft steroids and some lubrication. And the plan was to arrive at a diagnosis by further ASOCT, and if needed, need be excision or a topical chemotherapy. All those options were discussed with her. So for whatever it's worth, the UBM was done. It was shown that there was an episcleral mass, but wasn't the sclera wasn't involved. And anterior segment OCT, the image was very inconclusive. But at least we could rule out that the epithelium. It wasn't the epithelium which was involved. It was a subepithelial mass. So I thought my plan was to buy some more time, and I discussed this case with my seniors at Shankar Netralaya, and I also said, barring any sudden growth in the mass, we have an option of observing and doing an excision biopsy at a later date. So it was discussed that she would see me after a month. So except for a minor quietness in the eye, the mass remained just the same. So 1 month follow-up, she couldn't make it, but over the telephone, she was extremely comfortable, and she was unable to come for a repeat photograph. So my question to the panel, whoever is there, Dr. Paras and others, so how would you look at it? Would you initially suspect this as a malignant lesion, and would you aggressively look at it as insist on an excision biopsy? Should the patient choose to not opt for excision, can it be safely observed? Are there any perils in waiting or delaying the excision? And any different thoughts on etiology or the approach to this case? With this, I end my discussion.
So thank you, Priya. I think we'll take the discussion later. Meanwhile, the donor is getting dissected. So Rajesh.
Dr. Fogla, thank you for a beautiful dissection. It was a lovely clean bed at the end. I'm guessing you've refined the donor. Can you tell us about what you're doing right now? We can't hear Dr. Fogla.
Can we have the audio from the from the OR, please?
Yeah.
Yes, Rajesh. So, what was the size? What size would you plan for this case? And if you can tell us something about
it's an ectatic disorder, so I will use the same size donor, and we use 8.75. So we'll use a 8.75 donor. The tissues they had, I think there is some confusion. They gave me the pre-cut tissue, which I use, I think, for dissect.
So now you are going to do the...
I'm going to do the trephination, but from the epithelial side. I'm going to mount the tissue on the artificial chamber.
Okay. So I think
and then use the same suction trefine to cut from the epithelial side.
Okay. So meanwhile, we can ask Dr. Bhaskar if he wants to discuss.
I have one question for you, Dr. Fogla, before we move on. Why is it that you choose to trefine from the epithelial side and not the endothelial side as we traditionally do?
Number one, centration is much better. You can avoid the peripheral arcus or any kind of opacity. When you punch from the endothelial side, invariably you do get the peripheral edge of the opacity is visible. Second is, if you cut from the epithelial side, the same configuration of the trefine is maintained. You know, when you do a suction trefine, you don't really get vertical edges. There is a little bit of splaying posteriorly, you know. So when you do it from the epithelial side, the matching is much better. The donor fits much better.
So have you completely moved on to this?
Most of the cases, yes. I use the same. Yeah, the epithelial side.
Thank you so much. Dr. Bhaskar, could you just discuss the previous case and any comments?
Yeah, for Priya's case, basically, Geeta had already given a differential in terms of how you would approach a subconjunctival lesion. The OCT showed that the epithelium was okay. It was a subconjunctival lesion. OCT or UBM will not give you your diagnosis. Your diagnosis is ultimately going to be a histopathological diagnosis. You would give a course of topical steroids in terms of BLRH and it might respond. But if it is not responded, I would want to do a biopsy to prove what the pathology is.
Thank you.
Okay to wait, or are we losing valuable time?
I mean, it depends on the diagnosis. So if you are doing a biopsy and it is BLRH, you've not lost time. If you're doing a biopsy, it is a lymphoma, then it's about a month later that you have diagnosed. So I would give a course of topical steroids for a month. If it is not responding, I would go ahead and biopsy it. This is just a small excision biopsy, which is fine.
Yeah, thank you.
Okay, thank you so much, Bhaskar. Let him discuss. we'll continue with this. So, Rajesh, as you are beginning to now dissect your donor, can you please describe? Dr. Ritu has a question. Meanwhile.
Yeah. So I have mounted the tissue on the artificial chamber.
So, Rajesh, just for others who may not have access to this artificial chamber,
they can all buy one from Joja Surgicals.
No, that's true, but you know,
it's not very expensive.
Yeah.
But or yes, you can punch the conventional way as well. It's not that it will not work.
No,
but you can see that
definitely ideal, and even the badentrophine, because if you use the badentrophine again, the cost goes up.
No, but if you're using it on the patient's eye, it's the same trifine, you know.
Yeah, but still, you know. So, but short of that, of course, these are ideal, but you can go ahead and use the other trifines also.
Absolutely,
so
you can.
Manual trifines, and you can use a Teflon block. And
yes,
you can use a Teflon block and then trifine.
So now you can see that we got a very nice.
Did you put Helon in the artificial antechamber to prevent a sudden decompression?
No, I did not. So you can see that we got a very nice button.
Yeah, perfect cut.
Look at and if you look at the edge also, you can see that it's kind of a little bit of posterior splaying that you can see, but it's otherwise reasonably very well centered and beautiful button. Now, if you want, you can remove the decimates. And in this case, this is a young donor. I will choose not to remove the decimates from the donor, and we'll do a non-decimate removing DALK, which works equally well, and I don't make the inner surface irregular.
So this is the sponsor's call that this is, I think, the microkeratome by Moria that you're using, and it really works very well. It always cuts a little more than what you would think. I mean, the thickness will be more than what is really desired, as opposed to the other one, which comes from another company, which always cuts less than what is desired. Will it make no difference if you leave the desmids on the donor and you suture it?
I have not found
He has
any
left.
difference.
He's not dissecting it.
No, that's what I'm saying. If you don't, will it make a difference in terms of,
I have not found any difference unless you have a older donor where the decimates is not too healthy, or you feel that it's already coming off. Then you need to remove it. Now they've given me a tissue where you have the donor that's kind of, they have a cell count of 3,000.
Yes, this donor is worth for DSEC.
Yes.
I wouldn't use this donor for DALK, to be honest.
No, this is not for the one which we were for DSEC, we have already given back.
Yeah.
This is from their eye bank. It's optical PK, but this has a cell count of about 3,000. I asked them, I can harvest the decimates and give them for DMAC, but they don't have any case for DMAC as well. So otherwise we could have preserved the decimates and used it for a
DMAC.
Yeah, you can see that this is apparently a young donor. That's why the tissue is it looks very elastic as well.
Sometimes we use the tissue which is not suitable for optical PK for DALK also.
Correct.
And that time the cornea which we get is quite edematous. And when we are using it, the stroma may not be very thick, but while you're suturing, it gets thin. So even that, and there it's better to do a trypan blue staining on the endothelium side, and then you make sure that you have removed the whole of the decimates membrane with endothelium.
So any specific advantage of retaining the desmid, any post-op astigmatism or something you are not worried about?
No, in the sense that if you don't remove the decimates, and since this is a younger donor, what happens is you're not manipulating the internal surface. It remains very smooth. Now, if I go ahead and try to remove the decimates, and if I don't remove it, oh, sorry.
So that means you get a smoother bed.
Yeah, so this is what happens when you are talking. So what did I do? This is the cap which I had already dissected from the patient's eye. I
Dr.
put it on the
Pallavi
surface. Yeah, thank you.
So now, Rajesh, what did you do?
No. I had put the patient's the cap what I had dissected earlier. I had kept it on the surface just to prevent desiccation. And I was going ahead and suturing that only. This is the donor. So actually,
You realized right in time.
yeah. So that you see, that's the So if I want, I can remove the decimates from this, but since it's a younger donor.
No, that's why you thought the cornea was so clear, which you had.
No, I was thinking why the cornea is so thin. I thought it was very elastic because of the young donor.
Yeah, you said it is very elastic.
Yeah, that happens when you're talking, You keep talking and you...
So...
I kept it on the side and I forgot that I had to remove and put it back.
Yeah, that's a nice practice which Rajesh said, that to put the cap while he was preparing the donor.
Otherwise, it keeps getting dry,
Dry, because otherwise you've left a very thin decimates membrane behind, and at least that is protective while you're, those 10 minutes.
Correct.
Okay, so thank you, Rajesh. Now I think your live surgery will continue on one screen and we'll have the second presentation, please.
Sure.
But before that, I think he has to give us a suturing tip. How is he even suturing? Okay.
Let me call upon the next speaker from the previous presentation, Dilemmas of Creeping Surface Tumor, a case-based discussion by Dr. Pallavi Joshi. She is a consultant of cornea and ocular surface practicing in Bangalore. So, yeah.
Thank you. At the outset, I would like to thank the Cornea Society of India for this opportunity and Dr. Sumana and all of you for accommodating between the lamellar surgeries. So this is a case of tackling...
Sumana, we can see the name, yeah.
The tackling creepy tumor. So this was a 78-year-old gentleman who presented to us with redness and swelling in left eye past 1 year. He had undergone cataract surgery, both eyes, and he was treated for dry eye-associated redness and was on tear substitute. He otherwise still had redness always more in the left than the right eye. So on presentation, he had a minimal lid drooping and he had a diffuse sectoral congestion, which was more on the nasal, superior and inferior part. Vision was very good and posterior segment was fine. So when we see like this, probably it would have been a non-specific congestion he had. Only when we saw him on the extreme, we could see a gelatinous mass there, which was there on the cornea for around 4 clock hours, which was a little bit whitish with stain positivity only in that area. But there was a diffuse spread, which was there in the upper tarsal plate along the caruncle, and we could not see the posterior margin at all. So with this, we went ahead and did the UBM, which showed no deeper invasion. And we consulted even the oculoplasty department here. We wanted to do an MRI because the posterior extent was not seen. And it showed that there was a episcleral thickening, which was showing a on contrast enhancement was there, which was involving up to the medial rectus. So with this, what was the option? Whether we go and do an extensive surgical removal for this, or do a chemoreduction and then go ahead and do surgery, or biopsy with chemotherapy. We went ahead and did an institutional biopsy for this patient, and we also at the same time went ahead and did a interferon injection. So the biopsy report showed that it was a squamous cell carcinoma in situ with presence of mixed inflammatory cells, and there was no involvement in the stroma. So this patient underwent perilesional as well as combined injection because it was in the fornical area and topical would not be enough. And this patient till date has undergone 6 cycles. After the first treatment, the biopsy area was very healthy, and corneal lesion after 1 week actually showed near complete resolution. And the second week, we were able to see that majority of the congestion was waxing and waning. Only the bulbar lesion was persisting, which was more towards the medial side. Third and fourth week, the caruncle lesion was the only one which was there, whereas the tarsal as well as the corneal lesion totally resolved. Patient was simultaneously on 4 times with the interferon. By 5th week, majority had gone, but that persistent caruncle lesion was still seen. But inflammation had come down. And after 6 cycles, as you can see, this is the present picture. This is the latest, just 5 days back. And we have complete resolution in this patient. But we went ahead and did a repeat scan for this patient after 6 weeks. And according to the contrast, enhancement still shows there is a persistence of an area at the same area near the medial rectus, and however, no extra lesions. So with this, my question to the panelists and extreme faculty is, whether now we go ahead and do a surgery, or do we still keep repeating the perilesional interferon along with topical, and if so, how long? And whether in this case, we should even think about an addition of 5-fluoro, and what could be actually a repeat ideal time for a repeat MRI in such cases? So with this, I keep it open for discussion. Thank you.
So quickly, can you, Dr. Bhaskar, just give a comment?
Yeah, I mean, two things before we come to the question was, when you're looking at that kind of a lesion, you're looking at two issues. You're looking at either an MGDCA or a squamous cell. I would have first thought of an MGDCA in this presentation. So by doing a biopsy, incisional biopsy, to confirm what your tumor is, you've been able to exclude, I mean, confirm your diagnosis. Your lesion seems to have responded well. So I would probably continue, even in a normal ocular surface tumor, you continue it for a few months post resolution as far as your topical interferon is concerned. So I would continue the topical interferon for some more months. As far as repeating the MRI is concerned, maybe 6 months or a year, you can wait and do it. Your inflammation, everything was basically the tumor. That was what was causing the congestion. So once the tumor has regressed, the eye has quietened. So right now, continue interferon and see the patient another 3 months later. And I don't think we will probably need to do anything else. If you still have a doubt, you'll have to go ahead and do an incisional biopsy at the site of your rectus muscle where your MRI is picking up hyperreflectivity.
Thank you.
Thank you, Bhaskar. Dr. Fogla, quickly, we can see you're putting your fourth cardinal suture. Can you, for the audience, give a couple of tips of DALK suturing versus, other keratoplasties? Anything different you do?
Yeah, usually on the donor side, the bite depth is about 80-85%. And the host side, you try to go as deep as possible. And the width is slightly wider than what you may do in a PKP.
So can the audiovisual people see why there are blackouts in between? Please avoid this.
Also, can you just adjust the white balance so that we can see it?
No,
better?
the white balance.
No, now it is much.
It's perfect. It's perfect right now.
Yeah, I'm working with 5% illumination.
Oh my God. Okay, we'll move on to the next talk. We have none other than Dr. Ritu Arora, who will talk to us about repeat DALK surgery. So we have short 5-minute presentations, and then we'll come back to the surgery in between.
Thank you. I thank Cornea Society for giving me this privilege to give my talk on repeat deep anterior lamellar keratoplasty. We've seen a beautiful surgery which has been demonstrated by Dr. Fogla, but mind you, it's not that it's come overnight, and he spent years and years and mastered the technique. And so I came into this kind of a picture because I've been doing DALKs now for more than 20 years and gone through the learning phase, and in more than about 300 DALKs which I've done, I've had 7 cases where I needed to repeat it. So because of my learning curve in the initial phase, when I thought that I had done, when the bubble was not forming and I used to leave some tissue behind, and some of those cases I had to repeat later. We all know about the advantages of PK and DALK, and so I don't need to really go into that. These are the different cases in which we have done DALK, with the maximum indication has been keratoconus, but in macular dystrophy, Salzmann nodular, PMCD, post-LASIK ectasia, mucopolysaccharidosis, dermoid, spheroidal degeneration. So these are the different varied cases where we've done DALKs. The cases in which it has failed, and this has been the cause why the DALK failed in these cases. There was interface haze, recurrence of the primary disease, infection, HSV recurrence, or a type 2 bubble formation. And so when we review the literature on repeat DALKs to be done, I just came across 2 studies in which what is to be done in case a DALK has failed. And in one study which came in 2017, the repeat DALK was only done in 1 case of the 14 eyes which had failed, and they had done PK in those cases. And in another one, they had done in 5 eyes, they did the repeat DALK. So this was the main article of 2017, which talked about of the 14 eyes with graft failure, 12 eyes underwent PK, and only 1 eye underwent repeat DALK. So that's what strengthened my view that this is something which we should opt for in case the DALK fails over a long-term follow-up. And my DALKs, which I'm going to be showing, they failed after like 5 or 6 years of the first DALK which had been done. And this is a technique which addresses the cases of failed DALK. And most of the study reports the results of repeat penetrating keratoplasty following failed DALKs. And there is a paucity of study. So this was a retrospective intervention study, 7 patients with failure of primary DALK. Re-DALK was performed within 2 months to 6 years after primary surgery, and the follow-up period of re-DALKs is 1.5 to 4 years. The major indication for failure of DALK in my cases was, suppose we had done it for keratoconus, we get a lot of cases with severe viral keratoconjunctivitis. And in those cases, the chances of failure of DALK are there because there's a peripheral vascularization. Two of my cases had two eyes of one patient had primary corneal amyloidosis, and it used to recur. There was one case of interstitial keratitis, one case of Salzmann nodular keratopathy, and one case I had done primary DALK for advanced conus with healed eye drops and with atopy. He landed up with infection, and for this reason I had to do it. So the causes of failure, if I have to see, were these. And preoperatively, for all the cases, the most important information was to get an anterior segment OCT to know what was the residual bed thickness what I was dealing with. The host was trephined up to 90%, and then in some cases, the lenticule could just be lifted and the bed was dissected, while in some cases, I had to resort to a pneumatic dissection in 2 other cases. So I'll be just running you through this video of repeat DALK after having marked this. And though Dr. Fogla has shown beautifully the use of Baron trephine, but in case you don't have it, you can use a simple trephines which we use. Here you can see that DALK has been done, and then because of the vascularization, there are some cholesterol crystals with edema. So I have found a plane and I have removed the superficial failed or the scarred cornea, because this was my first re-DALK, so I really didn't know what I was going to be landing up. I had called Rajesh at that time, I don't know if Rajesh remembers at that time, that whether I should be attempting this or not. After I got the bed, I attempted a big bubble, and of course in my routine practice, I always decompress before I form a bubble. And I'm very comfortable forming a bubble with a 30 gauge needle. If you form the plane, if you find a good plane, the bubble forms in one go. And once the bubble forms easily, one can go and do a divide and see, this is there. The air goes, it forms a peripheral. Yeah, so here it has, you can see the plane has formed very easily. And then after that, I went and did a divide and conquer in exactly the same way as Rajesh has done. And I always mark, I put a viscose so that when the air comes out slowly. And this is the kind of a keratome, and he said blade up, slanting blade slash. Air comes out slowly so that you don't hit. I use a visco dissection. And this is the divide and conquer. And slowly, and then you can just go and peel off this tissue, and this is when the donor cornea is put. So this is basically the technique, and this I'm just trying to show you the picture. This is the pre-op photograph, and this is how the patient evolved. At 12 weeks, patient had a vision of 6/12. So this got me a confidence into that re-DALKs is a viable option. And this is the OCT, which is showing that I have left only 54 microns of the cornea. This is another case, which I had done the DALK long time back for Salzmann nodular keratopathy. And later I realized this was basically a deep LK and not really deep anterior lamellar keratoplasty. This was my LK, which I had done long time back. And after I really do the depth perception, with the micrometer, and I'm fond of using diamond knife, and then if you have a good tissue, it just gets lifted up, and I could see the vessels with the fibrosis and cholesterol crystal here. I tried forming a bubble, I couldn't get a bubble, but this emphysema over here helped me to remove, yeah, you can see the deeper layer, they just peel off, they peel off very, very easily. And the bed which is left behind is thin, clear, which is enough to support your repeat second tissue. As far as possible, it is always better to retain patient's own endothelium so that you give patient the advantage of maintained maintained and prevent from graft rejection. So this is the pre and the post re-DALKs, which you can see. This was a failed DALK, and this is how the patient evolved over a period of time. These are the OCTs showing that tissue which is left. This is another case of who had a failed DALK and had these vessels. This was a patient with atopy. I used a 9 millimeter graft, but the patient had a graft infection after that. So I had to wait bilateral advanced cone. And once the infection healed, I went ahead and did a re-DALK. I knew I was leaving a tissue behind, but that was a trade-off to get a patient had a patient of 636. This is another case who had post-interstitial keratitis. I had done the DALK, and he had landed up with this kind of these small infiltrates within a week after surgery. This was candida. So I just lifted off the tissue here. I had done a big bubble and put in another graft over here. So this is the series of 7 cases, 7 eyes, where we did the re-DALK. And you can say, except for one case, we could get a vision of 20/40, 20/60. And so it's a very viable option to do this, and which we published finally in IGO. So I'd like to summarize that this should be a preferred option if you are the surgeon and patient happens to be coming to you over a 20-year follow-up. So then only you see your failed DALKs. And because of the ease with which you can do this repeat surgery, and post-op visual recovery does not differ from that experienced after primary DALK. Thank you very much.
Thank you
I'd
so
like
much.
to ask Dr.
Thank you so
Namrata
much.
a question. When you're planning a repeat DALK, does OCT have a role in the planning? How would you decide what technique of DALK you will use?
So I think pre-op OCT plays a very important role, especially the high definition OCT, because you know at what level your DALK is, whether it's truly desmetic DALK or it's a pre-desmetic DALK. Also, if there's opacity due to infection, etc., then you know at till what level it has reached. Alternatively, like I always say, and I can't help saying it, if you do have an intra-op OCT, it again helps you to do the surgery and titrate your depth of dissection. Those were really complex cases, ma'am, and excellent job done, I think.
Thank you.
I have a small comment, ma'am. You showed one case where you had a interface fungal infection. In my experience, repeat DALKs always will have a recurrence if you do re-DALK in an interface keratitis. And I've burnt my fingers, and I've now decided that if it is an interface infection, whether it's a DSEC or a DALK, it's best to just do a therapeutic PK. That's the experience that I've had. Dr. Namrata, do you feel anything different?
I agree with you. I mean, I would run to do a PK and not do, especially in fungal infections, and not do a laminar procedure again. But I'm sure ma'am has a...
I could get off with it. Just luck.
Okay, thank you. I think Dr. Rajesh, since you're almost finishing the case, so would you want to tell us something about, give the finishing tips of how to finish such a beautiful DALK?
Also, can you tell us about combining continuous with interrupted? What is your technique? Are you using a no-talk?
Yeah, usually these kind of angulated sutures are no-talk suture. What you see here, what I have done in this case is I put a double running, and there is no interrupted. Even the 4 cardinal sutures that I had put, I've removed it. And somehow I feel that the corneal contour is much better maintained when you are using a double running suture. Just that sometimes it's a little bit confusing to apply these sutures because you are...
But again, he's done it very well. But for others who are just into it, please be very careful while you're suturing.
Yeah, so you actually have to maybe practice in the wet lab.
Yes.
Or at least make a drawing and get this thing correct as to how you're going to go about it. Because if not, you can get, like you see here, even this suture is going below this. So, I need to make sure that I don't entangle it in between the sutures. Otherwise, you'll end up...
Because you can even rupture at the last bite. So,
yeah.
I don't want to say anything, but I'm always scared till the last bite.
Only thing I would probably warn the listeners is that if you have a vascularized cornea, say a post-viral scar, then better to avoid continuous, then stick to interrupted.
And as you get better, like this case, there is no vascularization, no history of allergy.
This is perfect.
It's a simple, so it's important that make sure that your sutures are free, they are not entangled in anything else. And also when you're tightening, you need to know which suture to pull because there are so many
Yes.
running sutures. You can always get confused between the two of them. And if you don't give the adequate tension, then sometimes what happens is these sutures can become very quickly loose in the post-op period. And if that happens, then you have to go back and remove the entire suture, not just like interrupted sutures where you can do a selective suture removal and be done with it.
What I do when I'm doing a double continuous is I take the threads on opposite sides.
Correct.
So one set of threads is on one side and one is on the other side, so that they don't intertwine with each other.
Correct.
So thank you, Rajesh. Thank you for that excellent case. Can we have a huge round of applause for that big bubble and for the wonderful case Rajesh has done? I mean, it is really mind-blowing.
I think a big round of applause goes to the excellent arrangement at the operation theatre at PGI. The entire staff here, they have been extremely good. And I would say that it's been a pleasure operating here. We are doing it under GA, so the anesthetist team made sure that they gave the anesthesia on time. They put up a Zeiss Artivo 800, which is excellent. We just couldn't run the intra-op OCT, but if you would have done that, I think you would have seen even some of the steps as we would have gone ahead making the big bubble and everything. We could have shown you the exact happening on.
So
Rajesh, anytime it's happened with you that you've done excellent job and you are in for a surprise next day with a double anterior chamber. You've not had a perforation, you've done excellent suturing, but at any time, or maybe Rishi or Namrata, have you ever had this kind of a thing?
I've had it once, and I think it was missed perforation during suturing, and you end up with it, but they're so easy to deal with. You just need to put in a bubble of air.
So again, I would like to say that because of the intra-op OCT microscope, we see right on the table itself and don't get that in the post-op period. Can we have the next talk, please, by Dr.
Just a moment. I think Dr. Fogla was doing a very important step. You're kind of pulling away the folds in the stroma, I think? Or what were you doing?
No. There is a fiber there.
Oh, you're trying to get out the fiber. Okay. So I think that's an important thing, Dr. Namrata. Sometimes you see folds, and it's important to just do some centrifugal kind of pulling of the bed to avoid those folds in the bed. What do you do if you see those folds intraoperatively?
If I see them, I would definitely, pull them on one side. But sometimes what happens is that in the first post-operative week, you do see those folds, especially when your keratoconus is large because you're trying to, push that down. But over a period of time, they do disappear. So I really wouldn't worry too much. But having seen them, I wouldn't want to leave them there.
And they don't affect the vision much.
So can we have the second talk by Dr. Sharon D'Souza? Surgical case presentation related to DALK.
So we call upon Dr. Sharon D'Souza, who will be talking on surgical case presentations related to DALK. And she is a successful cornea consultant.
Hi, good morning, everyone. It is truly a privilege to be presenting in this session, and such a wonderful, beautiful case and great discussion. So I'm just going to talk about one particular complication or problem that I wanted to show. So we all, when it comes to DALK, I think we're fairly obsessed with the big bubble, and we always want that big bubble to come well. And whenever we get the big bubble, we're happy. When we don't get it, we're disappointed. But sometimes what happens, as I would like to show in this case, is we got the big bubble, but the next step is where we can get tripped up. So this is a little old video, so it's a little over illuminated, but you can see that yes, I got the big bubble. I'm just going to pause the video a little there to point out a few things. So this was a very, very thin cornea preoperatively. So I did what is the island technique, where you leave behind a little bit of the anterior stroma at the thinnest point and not de-roof that, and you get enough place to start your bubble. So fairly easy big bubble there, and there's the bubble in the anterior chamber which I've inserted to get the double bubble sign. So you know that your big bubble is intact, the air bubble in the AC is pushed to the side, and now I'm making what is the brave slash. And as Dr. Fogla very nicely showed in his demonstration that marking the area of the brave slash could help you avoid missing it. I'll just show you what happens, but it's not exactly missing the brave slash. So you go in and you get the brave slash, and I had applied viscoelastic on top of the area where I was planning the brave slash. So that, that helps in two ways. It slows down the egress of the air, and also you can see the air actually coming out. Okay, so you see the air coming out. But what happens next is that I just cannot find. I know exactly where I've made that slash, but I just cannot insert my scissors in to find it. I'm injecting viscoelastic to try and see if I can visualize it better, thinking maybe you can see the tiny little opening there. And this happens because sometimes we get scared. So what do we do next, and what did I do wrong? So I tried to think what could happen, and just a demonstration of what if all goes well, how it looks. So this is a fairly recent video. So this is the big bubble, and similarly a very thin cornea, so you left behind the anterior stroma there, viscoelastic on top, which I find really helps to slow down the egress of the bubble. And here you can see a much larger slash, and it's much easier to insert our blunt scissors and then deroof the posterior stroma and get a separation and get our bare Descemet's membrane there. So to try and think what else, why this happened and why such a small opening was made, I slowed down the video to demonstrate this a little better. And if you see, so initially when we started doing the brave slash, at least when I was learning in fellowship, we used to make a much more vertical slash to try and open it. But now all of us go in more horizontally, as Dr. Fogler was saying, and as was discussed, that you don't keep the sharp end down, the lower part of the blunt edge is down, and you're going in a more or less horizontal direction and coming up. If you see the video which is labeled as small Nick's load, and you see the hand movement, I go in horizontally, that is true, but instead of going upwards and out, I'm coming out almost in the same track in my hurry to get out and avoid a perforation. Whereas in the lower video, you can see I go in and then, move upwards and outwards, and that's the, possibly the better way of getting a much bigger incision. So a very small point actually, but it really does make a difference. And when we are in a hurry of the surgery, sometimes this may be missed. So what would we do in the eventuality that something like this should happen? And this is how I went ahead and managed it. So you can't really insert anything, not even an iris repositor sometimes. It's such a small incision. So this was a 30 gauge blunt rod, which I have. And once you do that, you put in that and then deroof with a side port or whatever blade is available. And you can easily expand that incision. And following that, it's a fairly routine surgery after that. So thank you very much.
Lovely. That is a very good point, and you have very nicely elucidated how to just withdraw in your brave slash. And I think some small tips like this make a large difference in surgical outcomes.
But I just want to add that sometimes when you actually enter in, it perforates at one particular point, but the remaining area stays lamellar. So in those cases, though you went in nicely with a rod, but if you can just take your cannula and just go first little vertical down and then make it horizontal, it goes in.
True, exactly.
Then also it goes in.
That's exactly what happened, I think, in the case.
Yeah.
That the tip, it was only the tip which actually went in of the blade.
Yes.
And the rest was very superficial.
Yeah, so if you'll keep going like this, you will not find it. But if you go and then go vertically down.
You need a very fine scissors.
So can we have the next talk, please?
Thank you.
Dr. Fogler successfully finishing his case, as you all can see. I call upon the next speaker, Dr. Vikas Mittal. He'll be discussing outcomes of DALK.
Thank you so much, and it was really a lovely video. It's really visual delight. We all, loved it. So what I'm going to do is just going to brief on how are the outcomes of DLK. So how I'll cover in three sections. One is outcome of DLK, then I'll compare DLK versus PKP and DLK various techniques. I'll run through the literature. So when you search DLK, you get more than 700 results. So there's a good amount of literature available on DLK. Out of it, clinical trials are 23, randomized control trial 15, and there are 8 meta-analysis as well. So let's see. So this study has 275 eyes of different etiologies. You can see 114 for stromal scars and 93 for keratoconus, and they have reported outcome up till 5 years of follow-up. So you can see the graft survival rate was 96% in 1 year, and even at 10 years, 71%. It was only corneal dystrophy which had slightly less survival, but otherwise the scar and keratoconus survival was almost equal. The endothelial cell density, since you are not disturbing the endothelium, so endothelial cell density was not significantly different in all the groups, and overall also it was very less. There was no statistical significance in the different kind of techniques of DLK, Bibbegal or viscodissection or layer by layer, both in visual acuity, endothelial cell density, as well as graft survival. The complication in this study was double chamber and rejection. Double chamber was mainly in the big bubble technique, and there was rejection which included both epithelial as well as stromal rejections. Another study which had 158 eyes followed up to 10 years, and you can see the both visual acuity uncorrected as well as corrected improved remarkably. Have a look at this cylinder and then keratometry, 60 diopter to start with and 45 diopter, and even in the post-op it remained stable. Endothelial cell density was pretty stable for all good up till 10 years. When they found comparing the manual DALK versus big bubble DALK, what they found was less than 5 years there was a difference, but after 5 years in the visual acuity there was no statistical difference. Overall graft survival 98%, which is huge. This study had the 660 consecutive DALK procedures and done on various etiology, keratoconus, scars, and cornealopasties. Both pre-descemetic and descemetic DALK had equal outcome, and endothelial cell density was also pretty stable. Average graft survival rate 99%. You can see the overall graft survival in most of the studies are coming more than 90%. This randomized control trial tried to differentiate between the femto DALK and a routine DALK, and they found that this was both functional as well as anatomical outcome. It was comparable. When you compare DLK versus PKP, so this study had 228 eyes of DLK group and 274 in the control group, that is PKP, consecutively done, and follow up till 30 years. Very nice study published this year itself. And there was no statistical difference between the BCVA of all the groups, and both in PKP as well as DLK. If you see the graft survival, PKP in most of the studies, most of the cases, both groups, PKP and DLK, it was very comparable. The intraocular pressure was on higher side in PKP group. That also only up till first year of follow-up. After 1 year, there was no difference. The early phase and late phase of endothelial cell loss was significantly lower in DLK group than PKP. It's pretty predictable, and otherwise if you compare the different kind of techniques, the outcome was similar. The overall graft survival, as you can see, up till more than 90%, even up to 20 years. And if you see PKP group and DLK group, more or less comparable. This is a very good review article which has again found that they have studied, he has reviewed 10 studies and found that DLK outcome is similar to PKP as far as best corrected visual acuity is concerned. And this is a very good meta-analysis which has included 16 clinical trials involving more than 6,000 eyes. And what they found was the final BCVA was significantly better in PKP eyes than in DLK eyes. And complications of higher IOP and cataract was more in PK group than in DLK group. The graft rejection was significantly higher in PK than DLK, and graft failure, there was no significant difference between PKP and DLK group. So overall, what they found was DLK has lower efficacy as far as vision is concerned, but has higher level of safety because significantly lower level of rejections and a lower level of endothelial cell loss. If you see compare all different techniques, Dr. Fogla and Namta Sharma has done this survey, and around 1/3 of Indian surgeons, they perform big bubble DLK. And those of us who don't have divine hands of Dr. Fogla, we can still go ahead and do DLK. Manual dissection. Manual dissection again is all you have to do is remove by layer. You can use a guarded knife to start with, to make 250 microns, and remove one layer, and then second layer, and then third layer. All you have to do is to ensure that when you are going in the second or third layer, the dissection is slower, so that you don't have any perforation, leaving rest is same, leaving some that 50-70 microns of stroma hardly matters. And this has been shown in various studies. Big bubble and manual DLK, hysteresis resistance is same in both the groups. The manual DLK has comparable results both in BCVA, UCVA, and there are multiple studies on that. And if you see this complications, most of the complications that has been described in literature are related to big bubble. So even the normal viscodissection layer by layer has also found to be equivalent. So overall, DLK appears to have a better graft survival in PKP if you see overall literature, and various techniques of DALK also appears to have an equal outcome. Thank you so much.
Thank you, Vikas. I think that was a very comprehensive overview of the outcomes which were covered very well. Anybody wants to make any comment, or we can move to the next talk?
I think we can go to the next talk.
So thank you.
I think it was very complete, so we don't need to add anything. Thank you, Vikas.
Thank you, Dr. Vikas. Now I call upon our next speaker for the session, Dr. Manpreet Kaur. She'll be talking on double DM after keratoplasty, OCT to rescue.
Manpreet, it's that side.
Dr. Manpreet is from RP Center, Delhi.
So Dr. Manpreet Kaur is working as now associate professor in the cornea, cataract and refractive surgery services of RP Center, and extremely bright and very nice surgeon. Yes, Manpreet.
Thank you, ma'am. So I'll be talking about double decimate membrane after keratoplasty, OCT to the rescue. There are no financial disclosures. So a double decimate membrane or even a double anterior chamber may be observed after both full thickness and lamellar keratoplasty. It's a rare complication in full thickness in cases with long-standing corneal edema such as Fuchs, congenital hereditary endothelial dystrophy, and in lamellar keratoplasty in cases with decimate membrane perforation during lamellar dissection, and if you have a type 3 big bubble. So the management, intracameral air gases have been described, ND-arc laser to perforate the second membrane, and OCT guided desmetorexis. So I'll just take you through two unique cases that we came across and how OCT came to the rescue in these cases. So this was the first case, a 28-year-old male with macular dystrophy planned for a big bubble DALK. So as you can see, after a partial thickness trepanation was made, the 30-gauge syringe was advanced and a big bubble was attempted. A successful big bubble was formed. So after that, the lamellar dissection to remove the superficial stromal layer, and then after this we'll make a nick so that the big bubble escapes and we can finally complete our dissection, the 4-quadrantic dissection. So everything was going on smoothly at this stage, and the surgeon was happy to have achieved a big bubble and thought that everything is going to turn out fine. There was no intra perforation and the lamellar button was then sutured successfully. However, on post-operative day 1, there were two distinct membranes that were observed in the anterior chamber, and on doing an ASOCT, what we observed was that the origin of the detached membrane was peripheral to the graft host junction, and then it split into two membranes, and there was one decimate and one pre-decimatic layer. So what was the mistake? What was missed during surgery was that a type 3 big bubble had been formed with both pre-decimatic and stromal separation and decimatic and pre-decimatic separation. So this was missed in the joy of achieving a big bubble. So how to manage this case? it becomes challenging when you do not recognize it on table and post-operatively. So there are two interfaces seen. So sutures were removed in the area where there was maximum separation between the two desmids and pre-desmitic layer, and a tiny nick was made, and then the air bubble was milked through the interface from the site where we have removed the suture. So Mericel sponge were used and surface corneal massage, so that at the end of this second intervention, the two membranes were well opposed with the stroma. The sutures that were removed were then replaced. So we continued with milking the interface and absorbing the air with Mericel sponges. So on post-operative day 1, we had an uncorrected distance visual acuity of 20 by 32 with a well-opposed graft and no interface fluid. So this was the second case, a 24-year-old male with a long-standing congenital hereditary endothelial dystrophy with secondary spheroidal who underwent optical penetrating keratoplasty. So the PK was uneventful. Post-operative day 1, again a graft edema with a retrocorneal membrane and a visual acuity of 20 by 40. So again, we did an ASOCT, and what we observed was that the membrane originated from beyond the graft-host junction. So it was not a detached desmids of the donor cornea, but a retained host desmids membrane. So ASOCT in this case as well was the key to diagnosis. So what was the mistake? Partial thickness trephination was made, hesitant AC entry. In such cases of long-standing corneal edema with thick corneas, this can lead to the desmids separating, and injection of OVD via the graft-host junction also would have further pushed down the desmids, and a pinching of desmids, attempted pinching over the iris usually helps to detect, but that was not performed. So how to manage such a case? So the OCT did not translate to a video recording. However, this was OCT guided. So what we did was plan a desmetorexis. So trypan dye was injected to stain the retained host desmids membrane via a posterior limbal incision, and then OVD was injected and a microforceps was used to peel off the retained host desmid membrane. The origin of starting the peeling off was done under guidance of OCT and from beyond the graft-host junction, so that you're peeling off the retained host desmid membrane only. So akin to a capsulorhexis, we could take out the retained desmid. Post-op uncorrected visual acuity was 624 with a graft clarity of 4+. So post-keratoplasty double membranes may be challenging to diagnose and manage. ASOCT is the key to diagnosis in the post-operative period, and IOCT is a useful adjunct to management to help guide the site of AC entry, avoid inadvertent interface entry. Real-time intraoperative dynamics can be observed, and you can ensure complete graft apposition at the end of surgery. Thank you for a patient hearing.
Thank you. Lovely cases, Dr. Manpreet. So Dr. Namrata, the first case, do you have some comments on that?
I think both the cases she showed were really nice, and earlier I think we had described trypan blue assisted desmetorexis for retained desmids membrane, and that she's shown in the second case. So the OCT, it was actually not retrocorneal, it was desmids membrane. So I think intraoperatively, Manpreet, what precautions for if you don't have an intraop OCT microscope and you are doing a case with chronic edema, what would you think you would do?
So one would be to avoid hesitant AC entry. Like we did a partial thickness trepanation, we made a nick through that area only and then injected OVD. So that would have pushed down the desmid further. So maybe a paracentesis incision to inject OVD would be better in these cases. And second, it's also said that you can pinch on the surface of iris to see if there's a retained membrane. So that does help in cases of long-standing edema to pick out if inadvertently you have left a desmid membrane.
That's a very good point which you said, that because it is a mistake sometimes when you're doing PK in long-standing and severe corneal edema, you may just inadvertently leave the underlying desmids membrane. So it's always a good practice when you are trephining, please go and touch the iris and see that you have removed the underlying desmids membrane. Good.
I found that when you're doing therapeutic DALKs in infected cases, sometimes even if you've not had intraoperative perforation or anything, sometimes you do end up with a double anterior chamber for some unknown reason, as though it's some sort of a transudation. Have you ever experienced that?
I agree. There is that fibrinoid kind of reaction, and sometimes that kind of forms a membrane in the post-op period. It does happen in therapeutic grafts.
I just want to add one thing here. Whenever you have a very thick cornea or a edematous cornea like this, you might do a debulking first. so that you go to the deeper part, you have a thin stroma, then subsequent management becomes simpler. So debulking is a good technique for these type of cases. There your entry will be much more guarded. You know that you are deep, and your cutting also becomes simpler, the graft.
I think another way to avoid a retained S-phase membrane is you can make a paracentesis and put viscoelastic into the anterior chamber first. So what happens is when you perforate, you will get some egress of viscoelastic through the site of perforation. If you are not seeing that, it means that you might have something which is preventing your viscoelastic. So if you put it through the graft host junction, then that will obviously come out. But if you put it from the paracentesis, the moment you make an entry, you should have some viscoelastic leaking out, so especially in thick corneas, that may not be a bad idea to do.
Okay, thank you. Thank you, Manpreet. Nimisha, last.
So continuing the session, we call upon our last speaker of the session, Dr. Bhupesh Bagga. He'll be talking on post-LK infections. Yeah. Dr. Bagga is a cornea specialist in LVPI, Hyderabad.
So I think after such a beautiful session, nobody wants to listen about infection, but sometimes it's a unfortunate event happened and we have to deal with it. So I have no financial interest for this presentation. Fortunately, incidence of post-ALK or post-DLK is not as common as we see in post-PK or post-DSEC infections, but there is an increasing trend of fungal infections in this, and this is the data from AIMS itself, that 11.11%, but they have included both donor and host factors. So there are two reasons why we see infections, particularly in DALK, donor-related factors as we see in post-PK as well, but recipient factors are also very important because there's a little longer surgery as compared to PK. Associated uncontrolled allergy, because many a times keratoconus is having an uncontrolled allergy, poor ocular surface, associated blepharitis, or epithelialization issue, BCL, loose sutures, that can give rise to infection. So I'll take you through some cases where we could see in a chronological order that how patients comes from 1 day to years together after post-DALK infection. And that slide actually shows it, that if at all is coming from 1 day to 5 months, how the organism and how the clinical manifestation changes. So this is the case of 30-year-old male who was having both eyes macular dystrophy, left eye status post-PK, right eye came for management. We performed DALK, and this is the first post-op day picture. So you see that everything was fine, patient was asymptomatic, vision was decent as bubble was there, completely attached desmet. And this is the OCT. There was nothing looked like any sign of infection. Because I am presenting the talk on corneal infection after post-DALK, I would like to see this picture again and see those fine, small, tiny, some spots and these tracy lines in the interface. So these were having a suspicion, but as you know, the DALK, post-DALK, first goal is always that everything is attached, there is no double chamber, and the patient was recounseled and started corticosteroids, but there was some doubt, so we caught the patient after 2 days. He came next day with this. So this was the impression I was also having. So that's what's there. So this is the post-op 2 days, and see the OCT of this patient again. And now you are seeing that you don't need OCT to confirm it, but this is definitely infection after interface. So we know that this is a 1 day post-op infection. Definitely it will be a lethal virulent bacteria, and mostly can be some sort of gram-negative or mixed infection, which is mostly multidrug resistant. So we decided to go for immediately penetrating keratoplasty and send the sample. But before that, we traced the other eye tissue, which is very, very important. So fortunately for the other eye tissue, we only have used in the same OR, and it was doing well. PK was done for the eye. So this was the urgent TPK, same day it was performed, and it came out to be Klebsiella pneumoniae, which was resistant to all except colistin, and we started colistin and patient eye could be saved.
So this is a patient of 21-year-old, DALK done for keratoconus. A little difference from the first case, where the 8 days post-op, regular post-op patient was called, and he was not having that many symptoms, but we could examine that something's there in the interface. So this is a smaller infiltrate as compared to the first patient where everything was so obvious. So this was, OCT was done, and on review of the records, it was a type 2 bubble, and it was a very advanced keratoconus. So a lot of stroma was left in the posterior, on this periphery, but the center was almost bare descimate. So we thought of this is infection. So but this was definitely a low virulent, most likely gram-positive bacteria, mostly a commensal, but we thought to take a sample, and while we are taking sample after lifting the flap, after lifting the graft, we realized this entire graft was having cellularity. So we thought of not to leave this graft. We removed the entire the button and removed this stroma as well, and we performed the repeat DALK on this patient. And it came out to be a gram-positive cocci, which was a Cucuria christini, which is none other than our other name of Staphylococcus epidermidis, but it responded nicely, and this is the post-op 18 months of the same patient where the repeat DALK was done. Okay, so this is a 12-year-old patient having very advanced keratoconus and came after 7 days with routine treatment after keratoconus post-DALK. But the lesion was a little different. On higher magnification, if you see, the lesions are interspersed between the sutures, but all are in the anterior stroma. So we scraped, clinically it was looking like a dry infiltrate and having a fungus. So it came out to be a fungus and grew also aspergillus flavus. So fortunately for the patient, it was only in the anterior stroma. And we started antifungal, stopped the steroid, but it was worsening. So we thought of taking patient for penetrating keratoplasty. While removal of the button, we realized that everything was in the anterior stroma. So we converted the plan on table and changed only to a DALK itself. And the patient after that did very well. We stopped antifungals after 3 weeks and started corticosteroids. So this is the different way of management. Now, little chronological order. Maybe 4 weeks, patient came with a little diffuse, little small whitish, chalky white infiltrate in the interface. We stopped steroids and followed the patient. And on follow-up, after 3 days, it came out to be a interspersed whitish colony, which is none other than Candida. Looks like most common infection in the Western country. We do not see that much Candida in the interface in the post-DALK. So that was the reason. Initially, it was not suspected. So we decided to go for complete penetrating keratoplasty, as Dr. Ritu Arora previously mentioned, that can be done. I usually feel that Candida, it's such an organism that we should not do a DALK, or at least reserve it, because Candida, if at all is albicans, it's fine. If it is a glabrata or tropicalis, they never leave you. So basically, the better to take out the entire graft, and this patient did well. So there are lipid deposits in this patient, which was referred to as a Candida infection. It was all loose sutures, 2 years graft. So I just mentioned this because all whitish deposits are not infection. They can be something else also. This is a very interesting patient where 1 year back, the DALK was done, and this child was doing well, but he came with the history of 10 days with the infiltrate, but not very symptomatic. So we scraped it, and we got gram-positive bacilli in V and L pattern, and it grew also. We started the treatment, but patient was not responding nicely. So in the previous records, which was like a paper records when we used to draw nicely diagrams, so there was a vascularized corneal scar, and the one picture we could find out there was a dendritic epithelial lesion. So we scraped and got the virus also. The IFA and PCR was done from the infiltrate. So not all infection need to be the same way. We did it with antibiotics as well as antivirals were added in this kit and started corticosteroids. And this patient actually responded nicely in terms of infection. This is the longest follow-up. 1971, the DALK LK was done, and 3 weeks history of blood vision referred to us for PK. So this was the patient diagnosis was written as pseudophakic bullous keratopathy, and so I asked the history, and they gave history of that LK was done, not the DALK. LK was done in 1971 for some scar, and the other diagnosis which was written in the graft rejection. So did the OCT, a lot of KPs and pigments on the desmet, and that was the picture in the OCT. So we thought of this may be a patient, this is a one-eyed patient of HSV corneal infection where the LK was done for the scarring, and so made the diagnosis of HSV recurrence and started corticosteroids and under Acivir, and this patient nicely responded, and he gained the vision as he lived the life from so many years, 20/125 with best corrected vision. So I think not all infections should be managed in the same way. And this is the patient where she came after 1 year of having edema and having KPs. So we diagnosed the HSV recurrence versus rejection. So this I showed in this picture to that all edemas and KPs are not always HSV recurrence. We need to be careful. This diagnosis is also important. 2% of DALK, all DALK can have reject. So we should having information of DLK rejection as well. So if time is there, just 2 more slides. So this is to cover DALK for infection as well, where not many indications except acanthamoeba or some rare indications for HSV and also for fungus. So this is the DALK done for acanthamoeba, and those who have seen or at least done acanthamoeba keratitis DALK, they should appreciate that whenever after 1 week DALK of acanthamoeba patient comes, it exactly behaves as we have done DALK for keratoconus, as for my experience. So, but this patient was behaving like this, and what the wishful thinking of all surgeons that this is not recurrence or this is not a rejection, this is inflammation which can be caused because we have done DALK in the inflamed condition. But this is the learning message. Whenever you are having inflamed condition, pigments on the endotheliums and confocal, there are 3 things. We have very, very important clue that your patient is having recurrence, and that continued steroids and it came out to be a bad recurrence. We performed a PK with a large sample, and this patient is doing pretty well till now. This indication is a contraindication of doing a DALK, and as you know that we have discussed already many times, cloudy infiltrate, long-standing history with KPs with raised intraocular pressure with more than 1 to 2 years history. Diagnosis is microsporidial stromal keratitis. Please never do DALK in this condition. I request it. Although it looks like very nicely, follow-up was very nice, but there are, you can see these whitish lesions, and these pigments are subtle signs, and sometimes it confuses with DALK, the PK rejection, and I have seen people are doing DSEC for that and sandwiched infection in the interface. So this patient fortunately picked up, got the recurrence of microsporia and did the large graft. So the key points for this presentation is identification of organism should be correlated well with the history from 1 day to 30 years. I have shown the cases. Interface haze is the early postoperative period should be observed very carefully. Careful management of poor ocular surface and allergy is mandatory for prevention of infection. As VKC probably is the common association of keratoconus and is the common indication of DALK in our scenario. Please first take care of that. And management is essentially surgical, except in few cases we have shown. Repeat DALK or PK should be thought of as case-to-case based discussion. Thank you very much.
Thank you, Bhupesh. Those are a beautiful collection of cases, and I think you covered the entire spectrum. One more organism that I've experienced is atypical mycobacteria, which can sometimes come in the interface as well, and is difficult to treat. In my experience, if the infection is in the interface, better to just do a penetrating keratoplasty. If it's in the anterior stroma, you could probably try and repeating deep lamellar keratoplasty. And virus has to be kept in mind, like you very correctly pointed out. I have burnt my fingers with the microsporidial doing DALK, and I think it never works. We have to do a penetrating.
So I think we will conclude the session. We've had a very good session, the live surgery as well as the talks, and 2 talks from the ocular surface session, OSSN session also. So we move to the next session. The next session
from the audience if they want any.
We won't have time. Okay, anybody would want to ask any question? My panelists are requesting for our audience question if there is any. Okay, so
Thank you. I hope you enjoyed the first DALK live surgery session. We'll request everybody to come for a quick picture and then the next session can take over.
So may I request the next session people to please join on the dais? Dr. Chintan Malhotra, Priya Desai, Dr. Himanshu Matalia.
Picture.
Dr. Benny Zheng. Divya is not there. Shizuka Ko. Dr. J.S. Titial, sir. Next session. And Dr. S.S. Pandav.